Welcome. I'm Clara McKay, CEO of the World Ovarian Cancer Coalition. Today's event is looking at the information and support needs of women with ovarian cancer and the role of patient advocacy organizations in meeting those needs. For those of you familiar with the Every Woman study, you'll know that we highlighted a series of deficiencies in relation to the experiences of women with ovarian cancer, including lack of information about ovarian cancer provided when women needed it, not getting support and information at the time in terms of their cancer experience when they needed it most, not being signposted to other sources of support and information outside of their immediate care circle, and limited time spent with women at the point of diagnosis. So we want today to explore some of these issues. We're going to be talking to 3 women who have personal experience of ovarian cancer to hear about their specific experiences and their perspectives on the information and support needs of other women as well as themselves. We are joined today by Andrea Kroll, who is the founder of the Association for Ovarian Cancer in Germany, and also someone who has had ovarian cancer herself. Dr. Alison Farmer, who is a psycho-oncology clinical nurse specialist based in the UK, I believe practicing in Southampton. And Dr. Magna Datta, specialist clinician in obstetrics and gynecology. Magna is based in the UK and works in the UK healthcare system, but also has a lot of insight and direct experience in relation to family members in India. So we hope as part of this, we can bring in some of those insights as well. So welcome all. We're really delighted you can join us for this important discussion. So maybe if I start by asking you really each to kind of introduce yourself and say a little bit, as much as you're comfortable with, about your own experience of ovarian cancer, and really just a brief reflection on your experience in relation to what your needs were and how well you felt they were served. And perhaps, Andrea, if I could start with you.
Yes, hello. Thank you for being here and thank you for networking with all over the world. I'm very pleased with it. Yes, my name is Andrea Kroll. I'm from Germany and I have had ovarian cancer 8 years ago. I'm a survivor of ovarian cancer. But since then, I founded the Association for Ovarian Cancer in Germany, and I try very hard to network and to get information all around the topic of ovarian cancer, to give it to women who are still ill or become ill, and as well to doctors for the needs of women which they have and often not spoken about it.
Thank you. And Allison, if you could introduce yourself. Oh, I think you're still on mute.
You'd
Perfect.
think I would have perfected that by now at this stage of the pandemic. Hello, my name's Alison. Thank you for inviting me today. So I was diagnosed with ovarian cancer 20 years ago this year. I feel very, very lucky that 20 years ago, I feel I got gold standard treatment. And it's quite shocking to see that some women, even now around the world, are not getting the treatment that I got 20 years ago. I'm a psycho-oncology nurse specialist, so my role is to support inpatients with cancer in Southampton. I use my own experience, my own diagnosis to sort of inform what I do, not necessarily tell the patients, but definitely informs my work.
Thank you. And Magna?
Hello, thank you for inviting me here. I'm a gynecologist and obstetrician by profession, and I've been working in the UK for the last 17 years. I'm also an ovarian cancer survivor. So I have had treatment here in the UK as a patient, which was coming up to 5 years now. And I have actually, like Allison, have had a very good experience of the treatment myself. But I also have a genetic mutation. So my experience on the side of the family history side of things and the investigations leading up to the genetic mutation, I thought that was something that was probably not as great as I would have thought, because things took much longer than they probably should. But otherwise, from the treatment perspective, I couldn't have faulted my colleagues who treated me, but I guess that may not always be the same for every patient in the UK. And there are things we definitely can improve on.
Thank you so much. Thank you all. So maybe, Allison, it would be interesting, I think, to start with you, to ask you, you're a psycho-oncology clinical nurse specialist. And I think for starters, maybe you could tell us what that is, because I think it's quite crucial to this discussion. And what do you do?
Okay. I'll give you a brief idea of how it came about. I did a PhD looking at psychological aspects of breast cancer, and taught psycho-oncology, which is the psychological and social impact of cancer, at Southampton University for about 8 years. And when I returned to nursing in 2012, because I actually missed being with patients, I noticed I was hanging bags of chemotherapy, and the patient in the bed next door had tears running down their face. And I was so busy, I didn't even have time to ask them, how they were doing. And so I wrote a job description and said I'd just like to support patients, in patients with cancer. And I was incredibly lucky that the hospital agreed for me to do this. And I think it was very far-sighted of them, really, to to acknowledge that psycho-oncology was an important field. So a lot of what I do is what's known as deep listening. So I will sit with a patient for an hour, saying very little and just holding that distress and validating the feelings. And sometimes that's all people need, because we find that family and friends often say, be positive, you can fight this, don't cry. And actually they just want to express how difficult the experience is. So that's a lot of my role. I might use some cognitive behavioral therapy tools. So I've done a CBT first aid course. I've done some acceptance and commitment therapy training, and I might use tools from that to help people manage unhelpful thoughts, stay in the here and now, not get hooked by worries about the future or regrets in the past, because the now is the important time, when patients are alive and have a lot of living to do. And so it's helping people manage these difficult thoughts.
Thank you. And I want to come back shortly to that thing about time, because interestingly, it's something that's come up in all of our sessions, and I think it's a really important question. But I think it's interesting because you did your doctorate in breast cancer, and you've had an experience of ovarian cancer, and you work with cancer patients. Are there needs that women with ovarian cancer have, in your view, that maybe set them apart from other women's cancers or other cancers generally?
I think one of the things with ovarian cancer is that, as we know, it can recur several times, and people can have periods in between that recurrence when they actually live very well and have good quality of life. So that can be a little bit different to some of the other cancers. So I think helping them live really well, even if they have recurrent disease, because they can do that for many years. So helping them live well, signposting them to the sources of support. I think, as with most cancers, those peer support groups are really important. Sometimes with ovarian cancer, we do find that people have trouble attending sometimes. So I think we're still working on how best to do that, but the peer support is great. Early referral to palliative care, which sometimes worries people a lot, but actually it's more about symptom control, living really well with your disease. So I think really those are the things, and making sure people are aware of what support services are out there, some amazing charities. And it saddens me sometimes when I go to see a patient and say, have you heard of Target Ovarian Cancer, for example, Overcome? And they haven't heard about those charities. So they are a major important resource for women.
Thank you for bringing that up, because I think certainly as part of this series, we feel very strongly that our patient advocacy organizations are themselves a central part of the healthcare system. They provide crucial and essential services, and really just kind of showcasing that through this work. And so thank you very much for bringing that up. Andrea, so I'll come back to you just quickly, because you actually, you set up a network of support groups. And so you feel very strongly about the benefit of women coming together and sharing their experience. Did you do that because there was a gap? Is that what made you think I must do this?
Yes, that was my first impulse, that when I was ill, I needed somebody to talk to who has the same illness like me. And in all of Germany, there was nothing, only one group in Berlin, which was 300 kilometers from my home away. And so I started to build support groups all over in Germany, so that we have now 17 support groups, which are really good, frequented from women, and who have a big need to talk to each other about their experience. To invite doctors and get informations through their illnesses and through everything. And it's a good network, and I think the intelligence, the collective intelligence, doctors, family members, and women with ovarian cancer is the key here to come over with this illness.
Thank you. And Magda, because you are in the health service and you're, at the coalface, as they say, and I'm wondering about your thoughts about the whole issue about time. And that seems to come through as a very strong theme from certainly the women we've talked to and surveyed, that the time that their healthcare professionals have to spend with them is not sufficient. And do you want to talk a little bit about your work and how, does that resonate in terms of just not having time to do deep listening, for example?
Yeah, I definitely do think we do not have enough time for most of our patients. And that was something I probably wasn't so acutely aware of before I had been on the other side, because I was working in gynae-oncology before I was diagnosed. And at that point, I did feel we are usually a bit short of time, but I didn't really think of it from the patient's perspective, because it's obviously devastating for a patient to be given the news that they do have cancer, however early stage it might be. It's never easy. And in the NHS, we do have like a clinic with maybe 15 patients, and you can give them I have to say, I work in a hospital which is a tertiary unit, and I did have the privilege of having dedicated time. But even then, we could maybe give 20 minutes, and if pushed, maybe half an hour. And some of these patients, especially when you are giving them their diagnosis or telling them that the cancer has come back, 20 minutes doesn't seem to be enough for these patients, and that is something we struggle with. And most doctors would like to give them and nurses more time, but it is the pressure and the resources that we have, that we are always short-staffed. There are not enough nurses, that sometimes maybe a specialist nurse can do that role, but even they are not enough in numbers to provide that service. So I do think that is something which is lacking in the frontline services. So that's where maybe the role of a peer group or a support group, or holding a health and well-being day where patients can come and interact and ask the questions that they are not always able to ask. And in a clinic setting, it doesn't allow them to think of the questions. They may go home and come up with something. So that's definitely an issue. And I feel very strongly that we do not have enough time, and we do not counsel our patients well enough before, say, a surgical procedure, but even more so about the other social aspects of a patient who will have to live with the disease and the treatments and its effects. That's something we need to improve upon.
Yeah. And I wonder, I mean, it's such an important thing, and it feels in a way, you know, healthcare professionals must also be very frustrated themselves at not having the time and not, you know, having that, being able to have a quality relationship. And I, you know, I'm opening this up really because it's a very open-ended question, but do we, you know, we would say, let the patient advocacy sector in, let us be part of this. And maybe we don't do it's good enough a job of, you know, marketing. It's quite difficult, but, you know, any thoughts, like, is there any way we can, anything we can do to make people's experiences better?
Definitely. I do, now that I have been talking to your group for the last few months, and I have been a patient, and I count myself as a survivor. It's now 4.5 years since my treatment. So I now can look back upon it, and I do think that it would be great if these charities or the support groups, they did start to have interactions with the hospital management about whether they can start to maybe support these clinics, that when the doctors have seen the patients, they can maybe take them away and sit down with them for in an informal way for maybe half an hour, have a cup of tea, and just let them let them voice their feelings, or sometimes, like you say, just if they want to sit in silence, even allow them that time. And that would be a great help. I do understand that there are definite, it's not going to be easy, because it's like we have no clinic rooms, we are short of places, and so these are logistics that we need to look at. And that's where, I guess, in the UK we have the Maggie's Center, and I was very privileged that the Maggie's is across the road from the hospital I was working at, and we started telling our patients that, have you heard about the Maggie's, and it's just across the road. Do you want to go and have a sit down there and just see if you want to let your mind calm down? And that is sometimes helpful, I think, for some patients, if not all, because not everybody is the same. But that gives them an option, and there probably should be some kind of a fund that we need to raise some funding, where patients probably could have an area where they can sit down and maybe talk to, if not a doctor or a nurse, but somebody who has experience of dealing with these patients, and if they wanted to access those resources, they are available.
Thank you. And it was certainly a point that Jane had raised in our conversations earlier about, you know, her personal experience really being directly linked to the amount of time, you know, that could be invested in her or shared with her, you know, depending on where she was or what hospital. And she could very much see that it was all also about the time, you know, the time constraints imposed on the people in the system. But Andrea, you actually, told me last week too, that you have a training program. So you actually have integrated yourself and your organization, or you train, you work with healthcare professionals, correct? Do you want to say a little bit about that? Because it seems like a very good model to me.
Yes, I try, first of all, I try to make cooperations with good doctors and with research centers to ovarian cancer. And then I try as well to change perspectives, you know, that patients learn from doctors how they feel, what they have to do, what the problem is, as well as the other way around. And my training program is like that, to understand each other and to get a different perspective, so that the communication is on a varied level, let's say. And well, it works quite good. And I think through this good cooperation from centers and patient network groups, it's getting better.
Oh, that's excellent. And we do tend to focus, I think, on naturally, I suppose, on that point of diagnosis, that initial, which is clearly a very traumatic and time of need for women. But, you know, you have all lived with a diagnosis of ovarian cancer for varying periods. Maybe Allison, do you have, you know, what's your sense on in terms of how we understand how those needs might change and you know, and how we can support women, you know, not just that diagnosis, but perhaps the needs that, you know, things that come up beyond that?
Yeah, I think, I mean, when I was diagnosed, I was relatively young at 40. And the thing that struck me then, which I still don't think is properly addressed, is the need for support groups for younger women. I do remember walking into a support group and everyone was fairly elderly, and I just turned around and walked out again. I think it was a reflection of my emotional state at the time, but I really missed that. So I think addressing the needs of that younger group, which include fertility, HRT, etc., is really, really important. I think there's, you know, more work to do on that.
For sure. And that feels to me, I guess, you know, something that might be at the forefront of a woman's mind, but perhaps, you know, when the focus is on treatment and, you know, potential for recurrence, it may not really get into the frame. And you, I think, have quite a strong view about this.
Well, I was, my main concern at the time was infertility for me. And I, you know, was pretty vocal about what, you know, my needs in that area, and that I wanted to see a specialist. I wanted HRT, for example. And, you know, my gynecologist seemed surprised that I wanted to discuss HRT, libido, etc. You know, it is an area we don't talk about. Intimacy, sex, health professionals are not good at it. In a recent study I read, 65% of women who'd been diagnosed with gynae cancer said that no one had talked to them about sex.
Yeah.
You know, it's pretty shocking.
It is actually.
You know, the gynae nurse specialists, I'm glad you mentioned them earlier. I think they come top, you know, amongst the most important people for these women. They are absolutely vital, but they are, like every other health professional, really pushed for time and would love to do more. And I think if we could do anything, it would be fund more of them so that they had more time to spend with women. They're extremely skilled communicators. They know everything there is to know about gynecology, and they are happy to talk about intimacy and HRT and all those things, but let's just have more of them.
Yes, I couldn't agree more.
Yeah, and one of the things I do notice is missing is literature from all you amazing organizations. I'd like to see big stands outside every clinic with more literature on it. There's not enough presence within the hospital from these voluntary organizations, I think. You know, we are very lucky to have Macmillan and Maggie's, but we need tumor-specific literature.
Yes, I think that's true. And I think we had in a previous conversation as part of the series, we had a talk with some of our member organizations and the difficulty in marketing. And part of that is about the resource, I think, that patient advocacy organizations have, that it's not viewed, it's not, you know, viewed as a positive thing for an organization to be spending a lot on marketing. Yet that's often the only way that you can, you know, make sure that you're reaching the people that you need. It's interesting. So Magna, if you don't mind, if we could come back to sort of you talked about family history, and I know that you have direct experience in terms of your family in India and cancer. So I suppose two thoughts. One, you mentioned at the beginning about maybe there's not enough information or support around people who have or understanding people who have a genetic family history and what that means. But secondly, I think it just would be really interesting in terms to, if you don't mind sharing some of the contrasts, I suppose, in terms of, you know, not necessarily the needs of women, but the experiences in the UK and experiences and your experiences with your family members who have had cancer in India.
Yeah. So I actually have the Lynch syndrome, even though my own cancer had nothing to do with the Lynch syndrome. My sister and my mother have also had cancer. My mom's no longer with us, but she was diagnosed with colon cancer when she was 60. And she survived for about 8 years. And at that point, we didn't know that we have the Lynch. But when my mom was diagnosed, we started kind of suspecting it because her dad had passed away in the 70s with colon cancer, and her sister passed away in the 90s with endometrial cancer. But at that time, I was still in school. So, and when my granddad passed away, I wasn't even born. So I just had heard about these things. So when my mom was diagnosed, it kind of struck me that it is possible that we might have a mutation. But at that point, I don't know, it was all the treatment happening and everything, and she didn't get tested. Having said that, when I came to the UK, I spoke about this with my GP, and I mentioned that I'm a gynecologist and I suspect that we might have a genetic mutation, but would they consider referring me to the genetic services? And I did ask specifically to be referred, but at that point they said, oh, we'll think about it, but that never really happened. In the meantime, my 27-year-old young sister got diagnosed with ovarian cancer in India. And when she got diagnosed, we got her tested at the time. And we found that she did have the tumor had the mutation, and she also had the mutation. So she had an epithelial ovarian cancer linked to the Lynch. Following this, I again requested that me and my other sister, we are 3 sisters, we should be tested. And my own colleague here referred me to the genetic services, but it just took so long for the referral to come through and for the tests to be done. But by the time my test result came, I had ovarian cancer and was actually on the day the result came, I was having a CT scan for a pelvic mass. So it really, in my case, did not help me, although I had asked for this test to be done 3 years before I got diagnosed with ovarian cancer. So that's possibly could have been prevented, or maybe I would have been diagnosed at an earlier stage than I was at. Although my cancer was not, which is very curious, I have a germ cell tumor. I don't have a epithelial tumor, but I do have the Lynch also. So that was one thing I found in the UK, that with all the resources that we have and which is available, there was a huge time delay, especially in these really specialized services. To access them takes time, and if it took me this long, I don't know what the general public might, because they are not doctors and they probably are not so aware of the genetic mutations. Obviously, since Angelina Jolie and people know a bit more about the BRCA, but Lynch is still not high up on the list of family history cancers. So that's where something more improving the doctor's knowledge, the primary care GPs and general practitioners probably should become a bit more aware of that. And in terms of my family's experience in India, I think having said that, in India, there are 2 very different class of patients. One are the really poor, who probably will not be able to access all the treatment that are available, but to avail that, you might have to spend a lot of money. So it's something that is very sad that in this day and age, not all women across the world are going to get the same kind of treatment. my mother and my sister, we have to say we were lucky enough to be able to get the treatment. And even though my mom at the time of diagnosis had a fairly advanced tumor, and so did my sister, but my sister is now nearly 6 years from diagnosis and is doing well. My mom has unfortunately passed away since, but we did manage to get all the treatment that I probably would have been able to get here in the UK, and probably at the time delay was less, but that's probably because they had treatment in the private sector in India. The thing that is lacking in India is there are actually no kind of support groups. And say a 27-year-old, so her support group is her family, and me and my other sister, we are doctors. So we were kind of giving her the information and kind of guiding her in making her decisions, but there are no support groups. The thing that we are lacking in is probably people who have recurrent cancers, and supportive care and palliative care are probably nowhere near as good as in the Western world, because access to even basic things like opioid analgesics are really hard to come by. And the emotional side of things is the family is the main support, really.
And I think that's it's such an interesting contrast, and but also the point that you've made about family, I think, is also really important, and that people turn to their family. That often is where your support comes from. But and maybe Allison, if you could speak to this, how do we deal with the needs of families and caregivers in terms of the supportive care? Do they get any support generally?
I think where I am in Southampton, we're very fortunate because we do signpost family members to our Macmillan Centre, our Maggie Centre, for example. And again, the gynae nurse specialists will see family. I think it's sometimes it's getting family members to acknowledge that they need support.
Yeah.
Particularly the male partners of our patients don't often want to access that support. People have said to me, I don't want to seem weak, or sometimes one of the issues is the patient's partner might have a completely different coping strategy to the patient. So the patient wants to talk about it, wants to be very open, wants that support. Her partner is in complete denial. It's far too big to acknowledge this, so let's carry on as normal, keep working and not talk about it. And I find that's the biggest conflict for people, when they have completely different coping strategies.
Interesting.
So sometimes I will see people together, sometimes I'll see them separately, but as long as we keep signposting people to that support and normalizing it.
Thank you. And Andrea, I remember you did a video for us a couple of years ago for World Ovarian Cancer Day, and you talked, and when we've spoken recently, very passionately about children and families. And do you want to say a little bit about that?
Yes, it's not only the woman who needs support as well, the husband and the whole family, especially women who are divorced and alone with kids, for example. It's a big problem as well. And if the kids are small and little and young, they even need more support at all. And yes, that is a big problem which is not seen yet in its full variety, let's say. Even though friends, best friends, woman friends, girlfriends, let's say, from women who are alone, divorced, and with no husband at home, need support. They all need support, and therefore we build up as well support groups for relations.
Brilliant.
We have 3 online right now, and we see that it's so important that they also get medical information as well as psychological information, how to treat somebody who has cancer, as well how to talk with kids about cancer, or about dying, or about anxieties. It's so important.
So important, I think. Go ahead, Allison, please.
just on the point of people who don't have a partner, often people think, oh, there's no point in talking to them about intimacy and relationships because they're single. It's absolutely not true. It's often a big concern is, how do I form a relationship after a diagnosis of cancer? And the support of our patients who have young children, is often for those women who are in hospital. All their concern is about their children. And how to support them. And I think it's such a crucial thing to do this really early on, to talk to people about the best way to support, how to make memories, what support services are out there. Some wonderful charities like Winston's Wish, all sorts of things. It's absolutely crucial. You get one chance to do this. And using that literature that Macmillan provide, talking to children and teenagers, absolutely vital. How we talk to them, letting the schools know, being really open, will make a difference all their lives.
Thank you. And Andrea, you wanted to come back in on that.
Yeah, they need as well contacts, addresses where they can go to and ask for help, for kids. Or there are so often as well women they are single and they have an animal, a pet. And it's the same problem with kids, more or less. They are so concerned about their pet, their dog, and they need addresses, a variety of help influences so that they can cope with this situation.
Thank you. I have one last question, and it was a point that Jane made when we all met earlier, and I thought it was really interesting. So I'm going to just kind of put it out there and then see what you think. So Jane Hatfield said that she thinks there's something about ovarian cancer that's a feminist issue. And just, I wonder, do you think there's merit in that women's needs and experiences might be seen through a lens that's about how women's health and societal views about women? And Allison, do you have a thought about that? I think it might kind of cross everything, rather not just supportive care, but just kind of women's health.
Yeah, I definitely think that there's some merit in that. It's interesting, isn't it, that testicular cancer gets a lot of attention, but it only actually accounts for 1% of male cancers, I think. It's hard. I'm sort of slightly conflicted. I absolutely do think it is about not talking about women's bits. The fact that so many women, from the studies that have been done, haven't even heard of ovarian cancer. How can that be true still, that people don't know about their genitalia? We often don't even call it the right names, I've noticed. So I think that is an issue, but there's also a part of me who feels that it's, when I've read some of the studies that show that women don't even have access to carboplatin and Taxol around the world, is it a luxury to start looking at the sort of issues of,
equality and access?
Yeah, I think it's very, very interesting. I think there's a whole other session probably.
Yes, I think there is actually. Andrea or Magda, did you want to come back on that? You don't have to if you don't want to, but I thought it was an interesting.
No, I do think there's very little information out there for women about ovarian cancer. Like we all know that it has been called the silent killer, but the thing is, it isn't silent really. Having said all of that, I myself, working in the profession, my tumor was 15 centimeters and I did not feel it because I wasn't looking for it. So I think it's just about repeatedly reminding women that don't ignore symptoms like just feeling tired or bloated is not normal if it's going on for 6 months. So it's as simple as getting a pelvic ultrasound scan done. And I know I have personal experiences of family in India and things are different here. So however unfair it might be, unfortunately, the world is never going to be an equal place. We should try to and strive for getting at least a basic amount of health care to every woman. But while it's great in an ideal situation, we have to use the resources that we have, and doing a CA125 and a pelvic ultrasound scan doesn't cost too much.
No.
So I think we need to keep reminding our doctors, from the general practitioners, and like their women also need to be educated, maybe in high school and things, that these could be the symptoms, so they are asking for these tests to be done.
Agree. I read something earlier today that said, and I'm paraphrasing, but why would we not raise awareness of symptoms that could be a sign of a lethal disease? Are we worried that we're sending well women, willy-nilly off to the healthcare sector? So it sort of kind of reinforces that thing about changing maybe our perspective on how people understand their bodies and, are symptom aware. Andrea, do you have any comment on that, last thoughts on that point?
Yes, I think, of course, that in Germany, at least, we are well trained. We are working in our professions, and of course, we fight for our right to be heard.
Yes,
and we should fight for our right to be heard. And as the medical world mostly is male dominated, it comes to changes. And we are the generation here which are 50, 60 years old and full in life, and therefore, yes, fight for your rights.
I'm with you. I think that's a great way to end that conversation.